A warm namaste to all viewers. So, Talk Evidence at AyurVAID is an innovative platform to showcase the excellent work done by our doctors in integrating Ayurveda with conventional medical care, which I firmly believe is the future of healthcare. I take pride in introducing our doctors team at AyurVAID Aster CMI Hospital, Dr. Rakesh Nair and Dr. Aishwarya Chand. Dr. Aishwarya Chand is a BMS graduate from Indian Institute of Ayurveda and Research, Bangalore. Apart from her experience of having worked as a physician in Kotikal, Patanjali and Raja Ayurveda, all in Bengaluru, she has dedicated 6 years of experience to Ayurveda, where she has made her mark in integrating Ayurveda with pre and postnatal care at Aster CMI Hospital. Now, Dr. Rakesh Nair is an MD in Ayurveda Dravyaguna from KVG Ayurveda Medical College, Bangalore. He brings to AyurVAID his experience of 8 years, having worked with Kotekal Arya Vaidya Shala and Birla Kerala Vaidya Shala, and his teaching stint at Hillside Ayurveda Medical College. In his 6 years of tenure with AyurVAID, his commendable role was when he played Braveheart while he headed an integrated COVID care center in 2020. He has also been instrumental in initiating co-managed care at Aster CMI Hospital, where he was able to deliver benefits of Ayurveda to patients undergoing conventional medical care with outcomes of par excellence. Today, we will be presenting a case, Integrative Management of COVID Encephalopathy, which was a patient referred to us from the internal medicine department at Aster CMI Hospital. Over to you, Dr. Rakesh and Dr. Aishwarya.
Thank you, Dr. Thank you, Dr. Kaveri.
Thank you, Dr. Kaveri.
Start.
Namaste. This is a case of axonal and demyelinating neuropathy with metabolic encephalopathy post-COVID. A male patient, 75-year-old, comes with the complaints of generalized weakness, especially in the lower limbs, and inability to stand or walk. He was bedridden, pain in the lower limbs from hip and below, and multiple joints. Because of the bedridden, he had bed sores in the right thigh and gluteal area, measuring 1 inch diameter. He was catheterized for loss of bladder sensation, altered sensorium. He was non-case of diabetic type 2 diabetes since 15 years on oral medications. He had undergone angioplasty 11 years ago, and also he had undergone lumbar decompression surgery 15 years ago. The diagnosis post-COVID encephalopathy with demyelinating axonal neuropathy and clinic bladder. Further details of the case, Dr. Rakesh will explain.
Good afternoon. So, keeping this patient's presenting complaints, he was, as Dr. Aishwarya said, he was bedridden. He was referred to us by the internal medicine department. From the presenting complaints, if you see, there was an existing line of prameha nidanas, which was underlined for past 15 years, where if you see the Samprapti chart, there is already existing of Kleda with Bahudrava Shleshma, which already Srotavrodha was existing. When Srotavrodha exists, we know that there is Agni Mandya and Vata Prakopa. Now, when in this underlying conditions, he also stepped into Astikshaya, where he had to undergo laminectomy status. With this, he also developed IHD, which is Rasadhatuk Shaya, which also led to Raktadatuk Shaya, Mamsadatuk Shaya, Medadatuk Shaya. At this juncture of time, there was an exposure of COVID. When there was an exposure of COVID, then there's a parallel Samprapti of COVID which is happening, which led to the influx or increase of the underlying principles, which led to the condition called as encephalopathy or Majjakshaya. This led to neuropathy as well as multi-drug resistance lower urinary tract symptoms also with neurogenic bladder. So this is the Samprapti which he developed. He was having an underlying principles. Further, it developed or exaggerated due to the COVID status. In COVID, there's a Garavisha. From Garavisha, there is Anavishta Raktam, which is Tikshna or Ushna Virya, lead to Sama Dosha, and the Ashaya is the Amashaya. Amashaya Samudbhava Roga. With this, the Sthana is in Amashaya with Raktadhatu, where the Samanana is affected. Hence, there is a complex pathogenesis which is occurring in this individual. We can analyze this with Dushya, which is almost all the dhatus is affected, which is Rasatu, Majja, Ojas, Mutra, and Purisha. The dosha is Tridosha Kopa, which is Vata Pradhana, Pitta, and Kafakshaya. Agni is affected, both Jatragni and Dhatwagni is affected. Amatvam is Sama, Srotas is Annavasotas, Rasavasotas, Raktavasotas, Mamsa, Medas, Asti, Majja, Mutra, and Purisha. Dushti Prakara of Srotas is Ati Pravriti. Ati Pravriti of Mutravaha and Raktavaha Srotas. We get the symptoms of LUTS, MDR, and urinary bladder. Sangha of Swedavaha Srotas, which is Jwara symptoms, which is COVID, post-COVID, and Sangha of Vayu, which is Gulma. Vimargamana of Majja, which is altered sensorium. Now, this can be validated with the reports. So when the patient was admitted under emergency department, you see his monocytes was elevated, 1.14. His hemoglobin was down. Then you see there is an E. coli of 1 lakh colony of bacteria on 2110. Urine routine, there were blood of 3+ with RBC 55. Then renal profile was normal except for sodium, which was very low. Chest X-ray post-COVID says there was multiple small patchy, inhomogeneous and reticular opacities, which is noted in the both lung fields. MRI brain says chronic ischemic changes in bilateral, periventricular, frontoparietal white matter. MRI of the spine says diffuse disc herniation with posterior protrusion causing moderate impingement on thecal sac, bilateral traversine, no roots. And there was a disc bulge in multiple areas from cervical to the thorax and lumbar region. So with this, the patient on 1st of September 2020, the patient had the symptom of fever and vomiting, for which he was admitted at one hospital where he was diagnosed COVID positive. When he was COVID positive, he was in isolation. 2 days later, he developed decrease in platelet count, decrease in counts, and dengue positive, which started with altered sensorium. He was then rushed to MICU of the same hospital. After 20 days of treatment, he was discharged from the first hospital with bedridden status, means he was unable to move. Weakness, pain, whole body pain, progressive, increases on sitting, standing, decreases on lying down. He has the inability to stand or walk, multiple joint pains, loss of appetite, and catheterized, and there is no sensation of bladder. And bowels also was irregular on diapers. With this status, the patient bystanders have taken him to hospital number 2 for treating these issues. On 28th September, he was also discharged from the second hospital with a conservative management from the existing teams of that hospital. From 28th September to 19th October, he was at home, bedridden, and increase in the above symptoms and increase in altered sensorium. The altered sensorium means he was not responding to calls, he was only drowsy, he was non-oriented, and he was non-coherent also. 19th October, he had approached AyurVAID hospitals and we had a teleconsultation done. 20th October, we told him to come and get admitted. Initially, it was admitted under the Department of Medicine for stabilizing sensorium and vitals. After 1 week, he was transferred to the transfer of care from internal medicines to Ayurveda. For 1 month, we have done the treatment till 26th November, and 10th December, he was discharged to home. During the stay, we had given the reference of vascular surgeon to see the note on the pressure source. On the pressure source, it says fungal infection of the bilateral groin, right trochanteric area, there's a superficial slough of 2 by 2 centimeters, healing margin, and no erythema. Then neuroteam also was given a reference for his ambulation status. So when they had referred grade 4 power in the limbs, sluggish reflexes, MRI of whole spine was done, where the report was says that there is multiple level cervical and dorsal spine called compression, but they were unable to do any surgical intervention because they feel it was not beneficial at this point of time. Then the case was referred to a neurologist to see whether a neurological opinion was done. Then NCV of 4 limbs was done, which suggested of motor and sensory axonal neuropathy, which means to say to consider steroids, nerve biopsy to be done to further work up, but steroids to be given, but there was no definite evidences. They also took an opinion from a neurology teaching institute at St. John's Hospital for this sural nerve biopsy. Once this was done, the patient said the neurology department had said we will try with Ayurveda, and then they have given cross reference to Ayurveda also. So when neurology people had discussed with this neurology colleagues, patient had developed weakness following a bout of viral illnesses. So the diagnosis was motor sensory axonal neuropathy. Nerve biopsy, the patient bystanders was not willing, and hence he was admitted to Ayurveda. So with this status and with this complaints, the Samprapti is being derived with the presenting complaints. Then once this is done, what was the Chikitsa Siddhanta? The Chikitsa Siddhanta at this point of time is post-COVID, or what we call it as Grahavisha. Grahavisha is the direct principle where the root cause is Viruddha. Viruddha Viryatvat Shonita Pradushaneyaha, which means the Shonita gets Pradushana. Yat kinchit dosham asravya na nirharati kayataha ahara jatam tat sarvam mahita mopadyatire. Means there is a dosha, utkrishta dosha happening, but no nirharana. Treatment for Viruddha and Visha are on the same principle. If it is not caused in Rakta Dushti, but Anavishta Shonita, which means Rakta is getting afflicted. Visha, which is opposite to Oja Guna, causes Ojo Vyapat and Bala Vyapat, which means when a Visha is getting increased, it's opposite to Oja Guna, it can cause Ojo Vyapat or a Bala Vyapat. The Chikitsa Paddhati involved for this gentleman from 2910 to 81 was intending to Amapachana, Srota Shodhana, Dushi Vishaharana, which is this medication, Shaddharana, Dashamula Paniyam, Pachanamrita Kashayam, Dhanvantara Goliga, Rashna Shundyadi Kashayam, and Dhanvantara Kashayam. Once we were monitoring on the Sama Nirama Lakshanas. Once we monitored the Sama Nirama Lakshanas, we went for Vatahara Chikitsa, which is with Dhanvantara 101 Avarti plus Brihat Vata Chintamani. Dhana Dhanayadi Kashayam, which is Vyadhi Vishishta, and Sahachat Kashadi Medugupagam, Ashtavarga Kashayam, and Chandra Prabhavati. After this, the second phase, he had developed UTI infections, which the line of treatment had varied, which we converted into CP Vati, Gokshura Churna Paniyam, Gulichari Kashayam, in the view of multi-drug resistance condition, Gulichi Churna Paniyam, and Gokshuradi Gugulu. The Chikitsa Paddhati is, the Kriya Karma is Dhanyamla Dara, Udvartana, Kshira Dara, Sarvanga PPS, Sekam, Shiro Dara, Pichu, Nasyam, Kaya Sekam, Dara, Vasti, and Stanika CPS. So to introduce what is encephalopathy. Encephalopathy means a damage or disease that affects the brain. It happens when there is a change in the way your brain works or a change in your body that affects your brain. Metabolic encephalopathy is defined as a diffuse cerebral dysfunction, typically manifesting as changes in cortical functions affecting the hemispheres, brainstem, and reticular activating system, and as disorders of conscious ranging from confusion to comatose. Encephalopathy is not a single disease, but a group of disorders with several causes. It is a serious health problem that without treatment can cause temporary or permanent brain damage. The demographics is any patient who is older than 65 years, where 8 to 70% of patients develop septic encephalopathy, is on a hospitalized patients, or 10 to 40% is gone. It is seen more of the geriatric cases. The two types of encephalopathy is reversible encephalopathy and irreversible encephalopathy. Chronic traumatic encephalopathy comes under irreversible, whereas and even hypoxic ischemic encephalopathy comes under irreversible. Balance encephalopathy encephalopathies are reversible. The underlying inflammations, where we can see a cytokine storm and a chemokine storm. In this patient, there was a cytokine storm post-COVID also. The inflammatory station was very high, which led to the endothelial dysfunction of the brain. The endothelial dysfunction of the brain causes malfunctioning of the blood-brain barrier, which enters into the cellular metabolism by entering the brain parenchyma. When it enters the brain parenchyma, there is a cellular dysfunction, oxidative stress and mitochondrial dysfunction, disruption to the neurotransmission. The disruption of neurotransmission leads to altered chemical functions such as GABA or cholinergic or beta androgenic chemicals, which leads to the functional damage. Hence, this can say that he was in a comatose stage or an altered sensorium phase. So when we understand this, we understand that there is a damage to the ojas. To understand the damage of the ojas, there is a lesson Vyadik Shamatva. What do we define as a Vyadik Shamatva? A Vyadik Shamatva is defined as when a health, which is a dynamically balanced biological environment, immunologically spread, when a foreign material is entered, which is inflammatorily or immunologically eliminated. Disease will arise when what is foreign cannot be eliminated or what is self or not spared. The mechanism of immunity is two types, which called as innate and adaptive immune response. This is the general sense of immunity, where the first line defense against the infectious agents or a foreign body does at the epithelial surface. It could occur in the eyes, nose, skin, anyways. The second line of defense is the phagocytic activity, which will kill them. This will induced phase, which is called inflammation. That's a response from the cellular level where the inflammation is induced. This inflammation induced leads to pro-inflammatory cytokine, a cytokine storm, or complement proteins, which is called as CRP. In the second line of defense, the phagocytic cells recognize the pathogens and receptors within them. So there is a count change. These two changes we can see in the blood test in the form of CRP as well as the difference in the count. The third is the adaptive immune response, which is mediated by B and T lymphocytes. That is the reason the lymphocyte count was changed. How do we assess Vyadik Shamatva from an Ayurveda perspective? General, a person is said to be in Sukha Avastha when there is no dosha prakopa. Vyadhi Utpadaka Pratibadhatva, or the resistance is reduced, leads to the development of Roga, or Vyadhi Bala Virodhitvam is reduced. It is assessed in three conditions: Sattva, Samanana, and Ojas. When the Sattva, Samanana, and Ojas is in tandem functioning, then we say the Vyadik Shamatva is good. Second Lakshana is Dosha Dushti Lakshana occur only if Samanana is impaired, which means a Dosha Dushti changes will occur when Samanana is impaired. Oja Dushti causes altered Bala. When Oja is affected, it causes Bala. So what is Ojas Dushti? Before that, what is Samanana? To understand more on Samanana, Sharangadra explains in detail about Samanana. He defines it as a balanced Tridosha functioning carried out through Mamsa, Rakta, and Asti Dhatus. The three Dhatus which to be assessed is Mamsa, Rakta, and Asti. In this patient case, Rakta, Asti, and Mamsa, there is a Kshaya happening, which means Tridosha is affected, which accounts for Samanana. In general, for a general person, Mamsa Samanana is for endurance, stamina, resistance. Rakta Samanana is by transformation, perception, and nourishment. Asti Samanana is clarity, highly active, easy execution of activities, and strength. This is the assessment of Samanana. Now the question arises, why do we assess Samanana? Because Samanana is the diagnostic feature in Ayurveda to assess Dosha Dushti Lakshana. When Samanana is impaired, Sattva is impaired, Ojas may be impaired, which can cause us ill health. So Ojas status can be explained in three. Ojo dysfunction can be explained in three status: Visramsa, Vyapat, and Kshaya. Visramsa means Visramsaha Sthana Chutihi, which means the Ojas displacement occurs. If a displacement occurs, then it is called Vishramsa, which is done because of Pitta and Vayu. The dislodgement takes place by Pitta, propelled by Vayu. Then we see a functional loss happening. When there is a Vyapat, Vyapat means distortion of Ojas. When there is a distortion of Ojas, Vyapat anyata patihi sa dushta dosha dushya samsargat. When the dosha dushya samsarga or the sammanahana is reduced due to interaction of dosha and visha, there is altered functioning. How the ojas has to function, it will not function properly. When there is a kshaya or when there is a less in the pramana or it's quantitative, then there is death. So with this critical piece, in this gentleman, ojas is been affected. Ojas is affected because of samhanana, sattva, and ojas. Ojas is because of the post-COVID complications. Altered functioning of samhanana causes ojo vyapat. Causes for tridosha dushti or visha nidana is agni dushti, repeated indigestion, habituation of viruddha, adhyashana, addictions, garavisha, synthetic foods, coloring agents, preservatives produce abnormal samhanana or direct ojo dysfunction. In this ojo vyapat, altered functioning of immune system could be seen. Dushi visha. Why is this dushi visha happening? Because dushi visha is the cause for ojo vyapat. Deha dhatu pratyanika bhutani dravyani deha dhatu abhividdopa apadyante, which means which is against the deha dhatu. Any dravya which is against the deha dhatu, which is not ill to the body, is considered as dushi visha. Viruddha mapi cha vidyat visham garopamam. Anything which is viruddha also can be considered as dushi visha. Visham hi deham samprapya prag dushyanti shonitam. What does it does? It does the dushyanti shonitam. Shonitam gets affected. Ojaso vipritam tat kshinai anvitam gunaihi vata pittotaram nrinam. So the ojas gets affected because of dushi visha. So how can we develop the dushi visha or how can we control the dushi visha? Vyayama snigdha deeptagni vayastaha balashalinam virodayapi na pidayet. So these are the people who doesn't get afflicted with dushi visha, who is continuously doing vyayama, who is incorporating snigdha, both bahya and abhyantara, who is having good deepta agni, who is vayastaha, and who is having good bala. Vishanam cha alpa viryanam yogoho gara iti smritaha. Virya alpa bhavat vibhamyetat kafavritam varshaganubandihi. So he gives a samprapti here stating that the dushi visha samprapti after going for rakta will have a kafavrita symptoms. So there is a tridosha involvement where rakta is involved plus kapha and avrita also is involved. In this gentleman's case, post-COVID, amashaste kafavata rogihi. Then, because of the underlying problems of inflammations, pakvashate anila pitta rogihi. Bhaven narod gwastah shiro ruhanago, which means because of the combination of both amasya and pakvashya combination, dosha dusha samurchana, it has hit the shiro roga, where encephalopathy has established. Sthitam rasadishu atava yatoktam karoti dhatu prabhavan vikaran. Here, the Dhatu Prabhavan Vikaran can be considered as an autoimmune diseases. This manifestation causes Abhishandi, which in turn increases Shleshma in Kapha Avarna and increases Marga Avarodha. So the events what had happened for this gentleman's case was in 28th October 2020, there was a transfer of care from internal medicines after regaining his consciousness with the status to confined to bed. He was able to roll, but he was not able to ambulate. He had severe pain, he had severe numbness, heaviness in the lower limbs, severe muscle wasting, catheterized, lack of strength, loss of appetite, disturbed sleep, pressure source in the right trochanteric area. It is at this juncture we had received this patient. 4th of November 2020, he was ambulated from bed to wheelchair. He was able to sit for longer time, more than 2 hours. His appetite opened. He feels hunger at proper time without feeling bloated. No gas. Bowels have opened. It was regular bowels on diapers. 9th of November 2020, 5 days after that, there was a clarity in speech and relevant speech. Pain and numbness has drastically reduced. He was able to stand and even walk for a few steps with support. Wound was completely healed and formation of granulation tissues was noted. 13th of November, he had complaints of burning sensation while micturition, which was secondary due to catheterization. It noted for sedimentation, marked purcelles visible, bladder wash was given. 17th of November, urine color had changed from dark yellow to orange reddish turbid with sediment. He was advised for urine routine and culture. 17th November, we are sent for a culture sensitivity where it was addressed with MDR, E. coli. 27th of November, phase 1 of Ayurveda had finished. Treatment extended for the objective of controlling recurrent urine infection and to strengthen the muscles. 2nd December, reference was given to internal medicines to tackle the urine tract infections. 8th December, repeat of urine shows decrease in the count, and 10th of December, he was discharged to home. So, what do we see here is there's a multi-specialty involvement in this patient's case. At the initial phases, it was an acute involvement, so the medicine department had taken care. Then, for rehabilitation and to get his vitals back, Ayurveda had taken care. During the course, he still developed drug resistance UTI, which again was physician. We had to take the help because we were tackling the other parameters. So this is the thing where he had 1 lakh again, second time. So regarding the outcomes, Dr. Aishwarya will take care.
So the time of admission, his appetite was very poor or Vishama, and during the treatment it was good improved, and the time of discharge it becomes Sama, and the sleep was poor, and the time of discharge sleep. In this case, in case of pain, the low back pain, the VAS scale was 10, and the time of discharge pain, even that is also like out of, and the time of discharge it is 0 to 1, it is very mild, and the numbness in the legs and hands also was very high during the admission timing, and during the discharge also it was very like mild. Even if you are going for the outcome scales, NIH score was 8 during the admission, while discharging 1, and overall neuropathy limitation scale 5, and during the discharge it was 3. So this is the outcome scales which we have to during the consultation, and the time of treatment starting date, during the treatment, and ending of treatment. So we used to take complete parameters, outcome scales, which is endorsed by patient. This is all those outcome scales given by patient. And the next scale.
So I'll present you the video where the patient himself explains about what was his condition before Ayurveda treatment and now.
Doctor, I'm very grateful to you for giving me this little few minutes to talk to you regarding the Ayurveda. Ayurveda is an ancient medical treatment that I could get from the different people, and I'm very happy that I could come to this institution. And for the past 3 months, I had different medical facilities, but I did not get any relief from them. And at last, I thought that I should join this thing. After joining, this is my 15th day, and every time I get a new treatment. Through this new treatment, I'm getting progress in my health. In the 15 days I was in a death condition. I could not move. I could not raise my hands. I could not. The pain was so much. But today, all the pain is gone, and slowly by slowly, and I'm getting a relief. And today, I'm very grateful to this institution. And this Ayurveda is not to second. Thank you, Doctor.
So, yeah, so you can see that the patient himself endorsed in that he was in a deathbed. Then after 15 days, after 1 month of his discharge, we again had a follow-up consultation where this gentleman is walking with a walking stick. He's doing well, and then he's following our instructions and following our medications. So with this, we would like to conclude stating this, that is, ज्ञान बुद्धि प्रदीपेन यो नाविष्यति तत्वित् आतुरस्य अंतरात्मानं न स रोगाम चिकित्सति, which means until and unless whatever knowledge we have, whatever things we have, until and unless we go in depth with the patient's understanding or patients, we see from the patient's point of view, no treatment is complete till then. So with these words, I would like to open up the panel for discussions. Thank you.
Thank you.
Hello, sir. Dr. Rakesh, sir. Congrats for your presentation. That was a wonderful session and very much informative. And seems you have gone deep into that case. And congrats, anyway, sir. And I think I didn't find any.
Thank you, sir. Thank you.
That's it.
Hello, Dr. Rakesh.
Hello, madam.
Congratulations, Dr. Rakesh, Dr. Aishwarya, for demonstrating really a state-of-art integration. And it also gives an idea that how various kinds of encephalopathies that could be treated. One is the point of that post-COVID encephalopathy, like that all toxic metabolic liver, all different types of encephalopathies could be handled this way, that once the acute part is over, we take over for rehab. So I have two quick questions which come to mind, where patient after completion of Ayurveda treatment and just about discharge showed like a bacterial UTI, which was multi-drug resistant. So at the time of encephalopathy, did you find only viral encephalopathy because of COVID, or was there a mix of infection which was leading to encephalopathy? Because as you said in the timeline, he was diagnosed later to be COVID positive. So
Okay.
was there any build-up before he was COVID? And should we call this as post-COVID encephalopathy or COVID encephalopathy simultaneous presentation?
Okay. So previous to the COVID positive, we have no, he was an active person from the history what we have taken. He was an active person. He's a member of his RWA, Welfare Association members, actively participating on the things and things like that. One fine day on 1st of October, he developed vomiting and fever, which he had we was there at home. It was COVID 1.0. So he was confined at home, taking symptomatic relief, which not come down, which not work out. So he had gone for a testing because that time was on the peak, first for 1.0. There he was diagnosed as COVID positive. By the guidelines, then he was on isolation. First line was isolation during 1.0. At that point of time, this dengue pathology also stepped in between, which triggered his total weaknesses, total oral pathogenesis, which even went to neurological deficit. That is the guideline which had occurred. When he was confined to the bed, he even lost sensation of passing urine also, which he was catheterized. From there starts the multi-drug resistance story. Now, your question whether the encephalopathy is prior to that, I would say would be a combination, a mix of this, because COVID has, it got COVID negative, but the inflammatory or the cytokine storms effect would have been still there, which would have caused some effect in the system associated with the bacterial part. Plus, all those things would have caused this encephalopathy. Hello. Hello? Hello, madam? Hello?
Anybody else would like to ask some questions in the meantime?
Sorry, Dr. Rakesh, I lost connection in between.
Yeah. So I was saying that encephalopathy of which cause is very difficult to say, but I would say it's a combination of multiple parts. It could be from the metabolism, metabolic encephalopathy plus post-infection plus active infections. Multiple things have risen for that encephalopathic causes.
Yes. Also, the reason to ask was that while dealing with post-COVID encephalopathy, you did stressed more on the part of Garavisha. So that could be an Ayurveda strategy to deal with while dealing with the encephalopathy changes, going to the cause of it. That this was because it was virus induced.
Correct. So anything which is Agantuja can be considered as Visha, which has an effect on Ojas. It could be Ojo Vyapat, Ojo Vishramsa, or Ojo Kshaya. The samprapti between the Visha to the Oja diffusion is what has to be tracked. And if a person is having underlying samprapti of other Kleda or Bahudosha Avastha or Bahudrava, as this gentleman, will flare up everything. So it will be like a combination of all, which a parallel samprapti for COVID also have triggered these underlying factors. Thank you, ma'am.
Good afternoon, Dr. Rakesh.
Good afternoon, doctor.
Very good presentation. So, to Dr. Janan's question, you were explaining about the samprapti of this case, and you were explaining about the Garavisha and the Dushivisha concept together somewhere in the slide. So, is that explanation done purposefully for this case? Means combining both the concept of Garavisha and Dushivisha together?
Okay. Yeah. So this is case specific. I'm not generalizing the fact that Gara and Dushi goes together. But in this case, there was a concept of both Gara and Dushi Visha. Why Gara Visha is because he's been on multiple medications, number one, unhealthy lifestyle, unhealthy diet, number two, okay, and number three is unhealthy lifestyle also, which is a cause for underlying Gara Visha. This one. Dushi Visha is because of the samprapti setting in post-infection. So it's in this case, it's a combination of both Gara and Dushi Visha, which has direct effect on Ojas, which had an easy access on Ojas. If a person has an access only on Dushi Visha or Gara Visha single, it will be in Alpa Virya, which will not have an access to Ojas. But in this gentleman, he had underlying samprapti of multiple comorbidities. Number one, his Kshaya was happening more. His dosha avastha was in very avastha. In that status, he has got both a combination of Gara and Dushi Visha, which triggered into encephalopathy or gone to the Shiroroga.
Yes, because that is quite an interesting reading, because the Garavisha will take time to manifest in the body, and that's not the case with the Dushi Visha. And I think that answers much of the modern pathogenesis of this case.
Correct. The lifestyle what we were leading was a amshamsha point of Garavisha, which was already been incorporated, which was a parallel samprapti of Visha was happening before COVID also. It would have happened. We don't know. But from there, from the history and then correlation on the history and things like that, we come to a conclusion that this is the plausible nidanas which can occur into this encephalopathy causes.
Okay, Dr. Rakesh. Thank you.
Thank you. Thank you.
One connected question, Dr. Rakesh. While he was being treated for all this, did you find a change in his viral load, like over a period of time? Because it was a viral encephalopathy, was that being tracked? Like it takes normally a time for RT-PCR to be negative, but did you observe that?
No, I was concentrated more on his sensorium, his neurological deficits and things like that. So my priority was on that rather than this viral load. Though the cause is this, I couldn't track that viral load of the COVID because previously it was not done. I don't know whether it will be done because COVID positive may have, may not have. I have no idea about that. Just have reference whether it is COVID positive. That's it. So I couldn't track that section. My priority was on this neurological deficit. Use it as possible before it becomes permanent habit.
Probably in future it could help us to correlate with the outcome, the
Correct.
correlation of viral load coming down and improvement of outcomes.
Yes.
Dr. Rakesh and Dr. Aishwarya, great job done. Also documenting the case very comprehensively. How did your modern medicine colleagues react to the whole progression? So, how was the interaction? Did they leave it completely to you? Were they also participating along with you in the co-managed care? So, could you just talk about the interface between you and the other departments, both of you?
From the time of admission
for the future.
Yes. Yes. So from the time of admission, the moment the patient was admitted, after 2-3 days, the reference was given to us. From then, the medicine department and we used to do joint rounds. We used to discuss the case and do the joint rounds. The vascular surgeon, the plastic surgeon doctor also had come and we had a joint discussion because he also had given his opinion on the ulcer part in the initial first week. Once his sensorium was better, then he said, why don't you take up the case? The medicine department said, why don't you take up the case? So he handed over a case to us. Once we handed over the case, after admitting under us also, the medicine department physician used to come to us. We didn't give reference, but he used to come on a daily visit and visit him. Plus, the neurosurgery department also used to come because we had given a cross reference what would be the neurological deficit, both neurosurgery and neurology. So on a daily basis, they used to come and have a rounds along with us and discuss and see the improvement. Once he started ambulating, they were all surprised for the fact that these changes had occurred because they were not anticipating these changes in the initial part. They told that they were confined to a bed, and they were already told the patient in the first that keep a home nurse, keep all the things ready, keep oxygen ready. He may be in oxygen requirement and all those things is required. They've already told. But once the changes occurred, the change was so nice that they all acknowledged very nicely. But the flow was in such a way that we used to do rounds together. We used to ask doubts. I used to go and ask doubts to them and said, what could be the possible things. They helped us in active bacterial infection when one lakh of E. coli was due to catheterization. The physician department came. He monitored and then he said that we do an IV fluids because it's very difficult for us to manage both neurological as well as this together. So he took part in that part and then he tackled the infection part. So it was a complete team, comprehensively team care.
So excellent, very glad to know. So could you just generalize that and go one step further, Dr. Rakesh and Dr. Aishwarya, that therefore, in certain types of complex cases, and you talked about the fact he was nearly at the dose of death, right? So from that, so could you generalize and say in similar conditions, what would be a similar generalized definition of a patient which could benefit from integrated management?
Okay.
Like the way that you did, that neurosurgery, internal medicine, and AyurVAID.
So here, when a patient is off acute, or in a life-threatening case, after coming out from a life-threatening case, stabilized, he could be in a tracheostomized case, or it could be in an NG tube case, or it could be bedridden, or it could be in coma state. So we have we go see the patient once and see that we fix an objective and say that this is what our objective will be in initial phases. We discuss with the consultant and say that we will be able to tackle this with a clear objective what has to be kept. Once that is done, we start joint care under the physician, under the main team. Under the main team, we go and add on, we do the therapy, which is called as a bedside therapy under the patient bed. It could be in ICU, it could be in wards, it could be in the isolation wards. We go there to the treatments and then to the ward and then do the treatment, bedside treatment. Our objective should match with the objective what we have defined. Once the patient starts to respond well from the initial signs, the second level of integrative is the patient is taken from there or moved from there to our treatment table. Still the patient is under the conventional care, but he goes for a next line of our treatment where he is transferred only for treatment from there to us, which is brought to our treatment room. Then once again the patient is improving well, or ambulating well or doing well, then the final touch is given when the patient is transferred to Ayurveda care, and then the treatment is taken off from there. Here the cycle is, the team is still the same, only the care is different. Initially, primordially, it is under the concerned department team where we had only value added services. Second, also will be under the main treatment where we also give value-added services. Once the patient is stabilized and things like that, we take care of the patient, we take over the patient, but still the main treatment will be our supporting care. There, we will be the primary caregivers, and then followed by the other rest of the team till the patient is discharged to home. This is the cyclic change, or the travel line patient will undergo for an acute. So here he is not developing any complications further on, or is not permanently disabled.
Just one quick, thank you. Just one quick follow-on question. When you do treatment in the ICU and in the bedside way, etc., particularly for such vulnerable patients, is there a risk of infection from the Ayurveda treatments and also the hygiene? So HIC in the treatment in the patient bed, because you're doing different treatments. So how do you manage the hospital infection aspect?
Okay. This we have,
because you might be doing, you said you're doing the ICU also. So how do you do Ayurveda treatment in the ICU?
So one thing is, we have discussed this with the infection control department also. One thing is, at that particular point of time, the only one thing we request we do the hospital is switch on for the few minutes the water at the fire part. That's it. The treatment is in such a way that the caregivers are well sanitized. Number one, very much they're properly gowned with the perspective of things. From the patient perspective, we ensure that the preparation of the patient is very much correct. Means we ensure that below the patient we keep bed sheets in such a way it's clean. We clean bed sheets so the linens are not soiled. Number one. Then safety precautions, induction cookers, small therapies are done with small objectives. During that course of time, the water and the water sprinklers in the fire is closed for a particular point of time. Number two, and post that it is wiped off. It would be powder, churnam, or it could be tailam. Then with the towel, hot water, we wipe that off, dry the patient, and then we come out of it. Ensure that it is cleanly gowned, and then we come out of the patient. So that treatment process could be only 15-20 minutes, but the whole length of the treatment would be take around 2 hours. Preparation, making the treatment room ready, making the set ready, and then yes. It should be such that the smoke should not become, so that indenting that the smoke should not come outside, because there are multiple ICU patients also there. Exactly. So smoke should not come out, so that monitoring and continuous monitoring. So myself or Dr. Aishwarya or the doctors will always be there with the patients, with the patient side till the treatment is finished. So these are the things which we ensure that taken care, and then post that we call the housekeeping guy, clean, and then clean the surroundings, sanitize that area, and then we come out of it.
Excellent. Thank you very much. So it gives us a bird's ringside view of what goes on. So my compliments once again. Thank you. Yeah, we'll leave for other questions. By the time the other questions come, this happened in January 2020 or 21. 1 year has gone.
Yeah.
How is the patient doing now?
Patient is doing excellently well, sir. He's now walking with walking stick, back to normal. He's now very active. He's taking part in the association meetings and his welfare association meetings. And he's a pastor, by the way. So he's into that, religious things. And
Good afternoon. Excellent presentation by Dr. Rakesh and Dr. Aishwarya. It was very, very good. But in between, I was interrupted by the patients and also in the treatment room. So I had to go in between. But anyway, I attended most of it. It was really excellent work. We also feel a lot of difficulty in actually carrying out the Panchakarma treatment in ICU. It is very, very difficult. They don't allow us at all to go to the ICU to do any treatment, because they say that the oil which you bring or the whatever the treatment, we cannot do all the treatment in ICU at all. We can do very, very minimum treatment we can do. The patient comes to when the patient comes to ward, then it will be easy for us actually to do. I was wondering actually how you were able to do the treatment in ICU. That was one thing actually. But anyway, you have done it. I really, my compliments to you, to both of you.
well,
And
I would like to intervene, sir. It is on the treatment objective what we fix at that particular point of time that we get an access to treat in ICU. It would be a minor objective, but for them it's a very major thing. It could be a simple treatment, but it is a very major things. We are not doing any internal medicines. We are only doing external treatments at that point of time. It is only small lagu treatments, small treatments we do there. But we ensure that we take responsibility in what in terms of infection control and cleanliness, which have been made it. So cases with that objective matches only we get that ICU doing the treatment. All patients may not get that objective. Depends on the case specific and the objective. But definitely there's a hope that we can do it in ICU is what I render, sir.
But the patient who is on a ventilator, the patient who is actually semi-conscious, we will not be able to do all kinds of treatment. In his case, probably he was conscious, he was not on ventilator, he was not on any other life-saving support, so we can do it. But in other cases, it is so difficult actually to do, what I feel. But anyway, you have done a good job. And then I would like to know
over the years,
whether
I've seen pediatric ICU in Dr. Rakesh. I myself have seen children, 5-year-old, 7-year-old in the ICU being treated by us with minor treatment. So I think the key part here is not the full pradhana karmas and the full bahya, the sarvanga treatments. It is maybe laghu treatments, but it's I think the key part which I also learned is the objectives are very clearly defined in advance, which is why it is possible.
Yes.
So I think that's a good lesson.
Yes.
Yeah.
So whether the homeopathic treatment and Ayurvedic treatment were going on simultaneously, and after taking over from them, whether they were also prescribing medicines further?
Yes, sir. Yes. When they were admitted under them for the initial phase, 1 week under the medicine department, we started our treatment. Once they were transferred to us, they were also prescribing. Our treatment was going on, their medicine also was going on. In fact, IV fluid also was given in short term because of his LUTS, multi-drug resistant LUTS. He was prescribed IV fluid. IV fluid was going on parallelly. Antibiotics was going on parallelly. His regular medicines of diabetes and then other things were all going on parallelly. Our medicines also was going on, and treatment also was going on.
Many doctors will be asking us actually, what is the clash between your medicines and our medicines? They always ask, your medicines, if at all they are acting against our medicine, how are you going to explain this kind of combination? Of course, combination is very good. Integrative approach is very good actually. But in between, we get many questions from allopathic doctors that whether your drugs are going to react with our medicines. We don't have any answer for that.
Sir, drug-drug interaction is a vast topic, number one. It can happen between two allopathic medicines also, or it can happen between Ayurveda and allopathic medicine also. We can't say. The only markers we have to see whether drug-drug interaction is happening or not is on one of the clinical symptoms, number one, and the second one is on the lab parameters of clinical efficacy of liver function and creatinine. That's it. This is only two nearest pathways which we can take or have a clinical symptoms. When a drug reaction occurs, there's a documented symptoms which we have. Is that patient getting that symptoms? Then we can say that yes, he's undergoing drug reaction. It can happen even in two multi allopathic medicines also, or it can occur in anyways. In this patient also, we ensure that all the integrative part, we ensure that a liver function and the creatinine test is done, plus a close monitor of the symptoms is also done, so that there is no drug reaction happening.
Yeah.
I think it's also the credit of Dr. Rakesh. I believe that he's been able to build the confidence with his colleagues on the conventional medicine side that they're willing to trust now. Over a period of time, they've done and built up the confidence, which is why they're being permitted, to do what they do. I think that is the key thing which I want to say. Right?
Sir, our colleagues here have gone in such a way that I give kashayam through RT tube, sir.
It's amazing.
Tracheostomy patients, RT tube. I give medicines through RT tube. Kashayam diluted, filtered, and then I give the medicines. With tablets also. I call it the tube.
To show the efficacy of Ayurveda, we want the like-minded allopathic doctors with us. Then I think we'll be able to show them, what is the worth of Ayurvedic treatment. That may be this. Yeah, thank you. And really, it was a wonderful presentation for both of you. Thank you very much.
Thank you, doctors, for the excellent presentation and the outcome.
Thank you, ma'am.
So since it is a demyelinating neuropathy condition, so what can be the future plan? What is the future plan in your mind for this patient?
Ma'am, we have been following up till last year with this patient. Patient is now not exhibiting any symptoms what is being charted out right here. He's absolutely fine. Okay, he is now come to a state where he only requires a walking stick for support. That's it. Apart from that, none of the symptoms what is being told, what we are discussed right now is not exhibiting. He's now into his conventional diabetic medicines, hypertensive medicines, and etc., with his own family physicians. So we told him that if any symptoms arises with respect to encephalopathy or with respect to any neurological issues like numbness or diabetic complications and things like that, to always reach out to us, which still is in touch with us. So always, that's not a problem. As of now, it's not going. There's no necessity for an intervention right now because he's doing good right now. He's comfortable with what is he doing right now with his own family physicians, with his conventional medicine. So I thought, okay, we'll let it go on this way. If at all any symptoms arises, we have educated him with some symptoms, stating that if you have numbnesses because he's undergone laminectomy status, if you have back pain, or if you have sensorium losses, forgetfulness, or if he feels that there's a shivering, or if he feels numbnesses, burning sensation, neuro conditions, immediately to reach out to us before it piles up into a bigger problem.
Was there any reflection of improvement of his other comorbidities like diabetes control or anything after our treatment?
Technically, I did not track HbA1c, which is my fault because my only concentration or priority here was on his neurogenic this one which was going on, because before it turns into a permanent damage, I would want to reverse it. So that's the reason I did not concentrate. So what was his regular medications? Of course, we are monitoring his fasting and postprandial on a day-to-day basis, which was on good terms. It was on normal terms, but we did not concentrate on that or things like that. But what I believed is by doing this cleansing or Shodhana Chikitsa, with this, even his sugar levels have stabilized a good way during the course. Present status, we have no idea because I only concentrate on the neurological part.
Okay, thank you.
Any more questions?
Just one thought comes in, which is the psychology. I know we are delaying, but one thought just came, Dr. Rakesh, Dr. Aishwarya. See, this is a very vulnerable patient, right? And you're treating them. It requires a lot of guts to take on such cases. Okay, even though you have the support of modern medicine, you do have the guts to take it on. So how did you manage the risk, right? Because you have to monitor the patient very closely, every few minutes, every half an hour, 1 hour, day, night, right? For this long period. So could you just, it'll be very interesting for all of us, like you told about the ICU, how do you manage the treatments, Lagu treatments like that. How did you manage the risk of such a high need patient?
Sir, that is the initial days till the patient was ambulating or till we get some signs where he was improving. Literally, I was tented in the hospital only. Day and night, we were doing even close monitoring in such a way that, even night also we were monitoring him to see whether in fact, his vitals were checked frequently in the night. He used to get up, again go for sleep. He used to cooperate with the vitals. We used to see his, daily changes, daily monitoring changes. What all was the changes with respect to our signs, Daily, I used to speak to a physician, neurosurgeon, and say that next what would be the things and things like that. So that was a learning process. That 10 days of this one, not to be everybody in the team was totally this one. Even CGs also had lost their sleep and were constantly with him only. He was with him only in the night. The CGs were there with him only. So the team effort closely monitored him, fully concentrated on him, monitor the symptoms, checklists of all, anything is there. We had early done the homework of what all could be the complications could arise. One could be that he could slip into comatose with low BP. Number one, he could go into hypovolemic shock. Second, number two. Number three is he could develop severe pain where he requires immediate intervention of IV fluid or injections. So those checklists we were monitored on daily basis for these patients. Loss of sensation. If loss of sensation is there, then immediately some intervention has to be done, epidural or some intervention has to be done so that the sensation is revived. Monitored is infection part. So frequent blood tests were done so that his infection was in control, especially the ESR, CRP, the cytokines and CRP and things like that. So there are multiple like this which were monitored on a day-to-day basis and then frequently for the first 10 days, 12 days. Once that was stabilized, then we got relaxed. Yes, he's responding. It came to a good extent that he himself said, I want to extend for next 2 weeks to get it more better. That's how that extension had also occurred.
Thank you. Very inspiring. I'll conclude by applauding you, Dr. Rakesh, Dr. Aishwarya, and your entire team of caregivers, Dr. Kaveri, for a great job done. Thank you.
Thank you, sir. Thanks.
Thank you, sir. Thank you, Dr. Rakesh and Dr. Aishwarya, for demonstrating that integrated healthcare is a game changer and it is healing oriented rather than just disease focused. The concept of integrated or co-managed care is definitely gaining recognition as an effective way to tackle today's healthcare crisis. And I also take this opportunity to thank Mr. Rajiv Vasudevan, our mentor, who has envisioned this and who's the main motivator to the entire team of AyurVAID. Thank you, sir.
Thanks.
Namaste.
Namaste.